بسم الله الرحمن الرحيم. In this lecture, we will continue talking about vascular hemodynamics. We explained previously that the blood flow is mainly laminar or streamlined, and we explained that it moves in layers. Then we talked about the parabolic profile of this laminar flow. Then we mentioned that in certain physiological or pathological condition, this blood flow becomes turbulent, not anymore laminar, so it moves in all direction, not in layers. And so there should be some sort of measurements to predict whether this flow will be laminar or turbulent. And this is what we call the Reynolds number, and Reynolds numbers basically compares between the inertia and the frictional forces in the blood. You may remember from your physics classes that inertia is represented or determined by the density of blood, or the diameter of a blood vessel, and the velocity of blood flow, whereas the frictional force is determined by the viscosity of blood. So the higher the Reynolds number, the more the tendency for the blood flow to be turbulent, which means turbulence is represented by dominance of inertia over the viscosity of the blood. And here are the density of blood. So basically, if the density of blood increase, the Reynolds number increase, so the turbulence increase. But actually, physiologically speaking, this density of blood is the least important factor because it rarely changes or rarely has a clinical implications. The diameter of a blood vessel is important, so the higher the diameter, the higher the Reynolds number, and the higher the turbulence tendency. Velocity of a blood flow. The higher the velocity, the more the turbulence of blood flow, whereas the viscosity of blood, which represents the frictional forces between the cells within the blood, the more the viscous the blood is, the lower the Reynolds number, so the less is the turbulent tendency to flow. Let's have a visual representation of the factors affecting the Reynolds number. And here we are comparing diameters between large diameter and a smaller diameter vessel. You see, in a larger diameter, there are more layers of the blood to flow. So the chance to be turbulent is higher than if it's just a small diameter. There won't be much room for this blood flow to be turbulent. So the more the diameter of the blood vessel, the more chance of the turbulence. How about velocity of a blood flow? You can see if the blood is flowing very fast, there is higher chances. Remember it as a highway. So if the cars are moving very fast, there is more chance for turbulence and moving in different direction. Whereas if they are moving slowly, there are less chance for them to be turbulent flow or disordered flowing of this traffic. Whereas in viscosity, which represents the percentage of the particles, especially the red blood cells within the blood, you can see if higher viscosity means more particles, so more frictional forces between them. There is no much room for them to cause turbulence. So the flow with higher viscosity will be mainly laminar. Whereas if we have less particles here, the chances for these particles to move in different direction or to change directions will be higher. So again, viscosity is inversely proportional to the turbulent tendency for the blood to move. So generally, laminar flow is silent, whereas turbulent flow is audible. This is where we hear the bruits, the murmurs, and all the sounds in the cardiovascular system that can we hear with the stethoscope. It's also the basis for the auscultatory method of measuring blood pressure. In this method, we put a cuff here attached to the mercury sphygmomanometer on the arm, and then we put a stethoscope on the antecubital artery. And so we started to inflate this cuff. While we inflating the cuff, we increasing the pressure in this cuff to exceed the systolic pressure. In this case, no more blood is flowing down the circulation. So you won't hear any sound. Now you start to deflate this cuff gradually until you start to hear the sound. And this represents the systolic blood pressure. You start to hear the sound because as you deflate it a little bit, you increase the diameter, so some of the blood flow will go down, but through a narrow diameter. So smaller diameter will increase the Reynolds number, increasing the turbulence tendency. And because turbulence is audible, now you can hear the first sound, or the systolic, which represents the systolic blood pressure. Now, when you continue to deflate this cuff, you deflate it so there will be no more sound can be heard, especially when they are widely open again. So there is no narrowing of the blood vessel, no more sounds to hear, and this represents the diastolic blood pressure. Normally, Reynolds number is between 200 to 400, which means a laminar blood flow, except at branching points or high flow velocity areas, such as the aorta. Whereas if the Reynolds number increases to more than 2000, it predicts turbulent blood flow in most of the vessels. Now, let's have a look at these clinical conditions. Do you think that this condition will have a higher Reynolds number than normal or lower? And why? Now let's talk about velocity. You know that velocity is the distance traveled by unit time. It also equals to the flow rate over cross-sectional area of the blood vessel. Let's see this example, which studies the relationship between the cross-sectional area and the blood velocity, keeping in mind that the blood flow is constant. So please pause the video and try to calculate the blood velocity for each one of these different blood vessels. By calculating the velocities, we can find that the higher the cross-sectional area or the diameter, the lower is the velocity of a blood flow. And so there is an inverse relationship between the cross-sectional area and the velocity of a blood. Now, can you guess in which segment of the vasculature do you think it will have the highest velocity of a blood flow? So it's the aorta that has the highest velocity of a blood flow, despite a large diameter in the aorta. So we talked previously that we compare velocity to cross-sectional area if the flow is constant. So now if we say that the flow here should equal to the flow in the major arteries together, and then the arterioles as a one whole segment, which is the cardiac output. Then we'll come to the capillaries, then the venules, and the veins. And so we have to calculate the total cross-sectional area. And because we have a huge number of capillaries, billions of capillaries, actually capillaries have the highest cross-sectional area, so they have the lowest velocity. This figure shows the cross-sectional area and the blood volume for each part of the vasculature. And you can see here in purple color the area. Capillaries have the highest cross-sectional area because of the huge number of these vessels, despite the smallest diameter. But this is very important to serve a function. So this high cross-sectional area that will result in lowest velocity of blood flow is very important for exchanging nutrients between the blood and the tissues. You need the velocity to be the lowest. Come next here the veins. the veins have also high cross-sectional area, so low velocity of blood. In addition to the other characteristics of the vein that we will talk about in details later, like compliance and distensibility, these veins have the highest blood volume in them. That's why we call them blood reservoir. This table shows the cross-sectional area per each type of vessels, and you can see here that the aorta has the lowest cross-sectional area and so the highest velocity. Again, this is important because the aorta acts as a conduit, so it transfers blood from the left ventricle to the smaller vessels, to the downstream vessels, after dampening the pulsatility of the blood flow. Whereas the highest cross-sectional area is in the capillaries, so lowest velocity. Again, it's important for exchanging nutrients and substances between the tissues and the blood. You can also note that here in the venous side, the cross-sectional area is higher than that of the arterial side. Now let's talk about the total resistance in the vasculature in series arrangement versus parallel arrangement. And let's start with the series arrangement. So you know that in the vascular system, blood flow from the arteries to the arterioles, capillaries, venules to the veins, and specifically within certain organ. And so each one of these segments will have its own resistance that's different from the other segments. The highest resistance will be at the level of the arterioles, as you know. So the highest drop in blood pressure would be at this level as well. So if we want to calculate the total resistance in this arrangement, it's actually the summation of the individual resistances in each of these segments. And so if we want to increase the resistance in any of these individual parts of the vasculature, actually that will result in increasing in the total resistance. For example, in chronic hypertension, arterioles will constrict, and so this will increase the resistance. As you remember, the radius is the most important factor controlling resistance. Increasing the resistance in this part of the vasculature will increase definitely the total vascular resistance. Now in parallel arrangement, like when the aorta branches to different arteries to provide the blood supply to these different organs and systems, this is in parallel arrangement, and so this is very important to allow individualized control of the blood flow, almost or relatively independent of the other blood flows in the other organs. And now the total resistance will be calculated according to this formula in the parallel arrangement. Now think of, if we remove one of these parallel circuits, let's say a patient came with a kidney disease that we have to remove the kidney. So we had nephrectomy for this patient. Now there is no parallel circuit at this time. What do you think will happen to the total resistance in this patient? Now let's talk about compliance, which basically is the delta V over delta P, or it's the how much volume can the blood vessel accommodate per change in pressure. We can study compliance better by studying this figure, which shows the volume pressure curve, and the red one is the arterial system, whereas the blue one is the venous system. So we want to see how much volume, the change in volume, how it would be accompanied by a change in pressure in both the arterial system and the venous system. Let's start with the arterial one. So if we're talking about 400 ml in the arterial system, that equals or that correlates with a pressure of a 0 millimeter mercury. Whereas if the pressure increase up to 100 millimeter mercury, the blood volume is almost 700 mils. So changing from 400 to 700 mils, that's a 300 mLs, will increase the pressure in the arterial system 100 millimeter mercury. Whereas in the venous system, as you see here, to start with, the baseline for the volume here is much higher, and the pressure values are much lower than that of the arterial system. So if we're talking about a volume of about 2,200 millimels, that represents 0 millimeter mercury. Whereas if we want to increase it like 300 mLs, less than 5 millimeter mercury, a change in pressure will happen. So you can see that veins are much compliant than the arteries. So you can change more volume of blood by little changing in the pressure. And this is very important, especially when we do like blood transfusions or giving fluids to the venous system. You may give a large amount of these fluids without affecting the hemodynamics or the function of the circulation, because these veins have a large compliance and capacitance. And the same thing when we lose some of this blood, these veins again act as blood reservoir. We can see also here the effect of the sympathetic stimulation or the sympathetic inhibition, both in arteries and in veins. And you know, by sympathetic stimulation, we are stimulating the vascular smooth muscle cells. In the arteries, we're talking mainly about the arterioles. So when you stimulate them, they will constrict, and so less blood volume will be occurring at each blood pressure. For example, there was 700 mils per 100 millimeter mercury in the normal situation, whereas if there is sympathetic stimulation, there will be only about like 300 mils in 100 millimeter mercury. The same thing for the venous system. So less volume per each pressure will occur. And this is important in cases that we need to increase the blood flow coming from the heart. So we do like shifting the volumes. In this lecture, we talked about laminar versus turbulent blood flow and the Reynolds number. We talked about the relationship between velocity of blood flow and the cross-sectional area. And we talked about the difference in total resistance between the parallel arrangement versus the series arrangement. And then lastly, we talked about the compliance in blood vessels by studying the volume pressure curve. Thank you for your time.